We're going to start the presentation just a few minutes after 1 o'clock. We said 2 past. Just enough. Let's wait for another minute. Well, our session today, our webinar today is going to focus on a number of studies that we have done in order to make healthcare safer for all the people living in care homes. We are all based in the Safer Care Systems and Transitions theme at the NHR Greater Manchester Patient Safety Translational Research Centre. I'm Maria Panagiotti. I'm leading the team of Safer Care Systems and Transitions. And Sally, who's going to follow, Natasha and Claire are all working as researchers within the theme, or they have personal awards working on the topic around patient safety and quality of patient care, either in care homes or in other vulnerable settings, such as mental health. Well, as an overview of our presentation today, of our session today, I will start with presenting the findings of a meta-synthesis that we did. Of a meta-synthesis that we did around infection prevention and control in care homes. This will take about 10 to 15 minutes, then around 10 minutes roughly. And then Sally Giles is going to present a framework that we have developed for patient safety in care homes. After that, Natasha, building on the framework that we have developed with Sally, is going to present a measure that we have developed, a patient-reported measure focused on getting the views of residents and carers about safety in care homes. And finally, we will present a study about interventions for improving transitional care for people living in care homes. And Claire Planner is going to present this, as well as some findings that we had, some findings from qualitative interviews, which focused again on how to improve healthcare transitions. So our overall presentation is about quality of care and patient safety. And we've got certain themes such as infection prevention and control, and developing a framework of safety, measures of safety in care homes, for particularly aiming to improve safety from the perspectives of patients and residents and carers. And finally, we focus on a specifically vulnerable point, which is transitions from hospitals to care homes, or the other way around. So, well, the title of the meta-synthesis is Beyond the Control of Care Homes. And it's a review of qualitative studies on prevention of infection prevention and control in care homes and nursing homes. Well, the COVID-19 pandemic has had a global impact on the care home sector. In the UK, rapid and mass discharges from hospitals have been the main explanation for failures in appropriate infection prevention and control in care homes. It is widely recognized, even before the pandemic, that residential settings are vulnerable to a range of hospital-acquired infections. And previous studies, mainly based in the US, have reported variability in staff adherence to infection prevention and control. There are a number of interventions, quite variable, and this might also include national care collaboratives. The aim of this meta-synthesis was to synthesize the findings from qualitative studies on IPC in care homes in order to yield insights into factors affecting transmission of infections into and within care homes. We chose meta-ethnography as a method of review synthesis because it offers the opportunity to develop a conceptual insights which go beyond the findings of primary studies. Our overall aim was to develop a conceptual model of the factors which influence infection transmission in residents of care homes for older people. Apologies for this, I just forgot to say that if you have any questions, please add this in the chat and we'll be able to respond to your questions at the end. We have searched several databases, 5 key main databases, including Medline, Base, PsycInfo, CINAHL, and ASIA. And then we also looked at Google Scholar as a source of wider lay literature. We included studies, published reports of studies using qualitative methods of data collection analysis. The studies had to be presented in English, and we included a range of participants, staff, residents, or managers of nursing or residential care homes for people aged over 60. And then the studies have had to specifically focus on infection prevention and control, not just mention it at some point, so it had to really be focused around this topic. We identified 5 studies which were included in the meta-synthesis, 5 international studies. Most of them were actually based in the US, but we also found a number of international studies, very few from the UK though. Our findings were mainly focused on 4 key themes. The first was about staff knowledge and attitudes and practice of infection prevention and control, and also in relation to how infection prevention and control in care homes interferes with workload and lack of time of resource that the staff encounter. Then the second issue was about problems with enabling staff members to enact IPC procedures and staff motivations or attitudes around practicing infection prevention and control. The third thing was that infection prevention and control was sometimes seen as less appropriate in care home environments, and the residents' views around IPC and IPC behavior were not always consistent with IPC practices. And finally, there were clinical issues, including the transfer of clinical information between health sector and the care home sector. So, I mean, roughly, our key findings showed that one of the key challenges faced by care homes is uncovering how an outbreak begins. Then, once an infection begins to spread, identifying who is responsible for the necessary control measures, it was not always clear. High staff turnover was also an additional challenge, as well as the need to bring in external health professionals such as GPs to diagnose or treat an infection which affects IPC. Overall, we found that training staff repeatedly could support them in ensuring IPC is effectively practiced within care homes and overcome one of the key reasons why infection prevention and control in care homes has not been seen as effective, which is actually high staff turnover. However, the success of this measure depends upon managerial commitment and organizational improvements that need to be made within care homes. So overall, this diagram shows the complexity of infection prevention and control in care homes. So one key aspect is about ambivalence, about the actual possibility of implementing IPC in a care home environment, and the tension between having a homely quality of life environment as well as doing a proper IPC practice. Then the second theme is about the credibility of the information used for IPC control in care homes. There were always delays and miscommunications between different sectors, healthcare sector and social care sector, as well as sometimes lack of information or suboptimal information flow between different sectors. Moreover, and this is an important aspect as well, because it was a bit different, but still interferes within the previous findings. It is about the opportunities for harnessing professionalism in care home staff, and this is perhaps the most important area that can inform interventions for improving IPC control in care homes. More about improving knowledge and training of staff members, but this again has to be done in a consistent way and supported by organizations rather than random or inconsistent training across care homes. So overall, and in fact, the key discussion findings are that an infection breakout would likely weaken IPC in care homes due to exacerbation of workload and additional pressures of monitoring. IPC practices can be almost antithetical to the notions of homely environment and create dilemmas for staff and patients. Key control mechanisms sometimes lie outside of the care home environment and could underline the view that IPC is something that care homes should not worry about. Key issues about IPC practice relate to communication between different staff members, between different sectors, and how to ensure organizational investment on staff training in relation to IPC. Thank you very much. And I'm going to pass the presentation to Dr. Shail Giles, who is going to present a systematic review for developing a framework framework of safety in care homes.
Thank you, Maria. I'm just going to share my screen. Hopefully everyone can see the screen clearly. So I'm Sally Giles, and I'm a researcher who works on the safety and transitions theme with Maria. And I'm going to present to you today the results of a systematic review looking at safety domains for residents in care homes. Okay, so why is it important? So poor quality and unsafe care provided to care home residents can lead to significant patient harm and even mortality. We also know that care home residents are twice more likely to experience emergency admissions than the rest of the population over the age of 75. And 40% of them experience adverse events within 45 days after hospital discharge. And we know that studies in upstream healthcare systems indicate that team working factors, communication, information flow, access, care planning and patient characteristics, as well as factors like task performance, may contribute to patient safety incidents. These factors have been used as an empirical basis for generating a framework of contributory factors to patient safety incidents in the hospital setting. And there is also a lack of consensus over the contributing factors to patient safety in care homes, with aspects such as organisational, residential characteristics and access to healthcare thought to contribute. And we know that safety challenges are likely to be different in care homes, where health and personal care is from multiple care providers, with a lack of continuity and the residents themselves being largely unable to navigate the health system independently or express their concerns effectively. There is also a lack of a framework to guide policymakers on which safety factors to target for improving patient safety in care homes. So what we wanted to do was to produce a clearly defined framework which describes hierarchically, ordered from the sharp end, proximal to distal latent contributory factors to patient safety incidents in care homes that feature more strongly in the literature. So I just wanted to give a quick definition of what we mean by contributory factors. So contributory factors were defined as any active failure at the individual, institutional or national level which threatened the provision of safe care to residents. They could be also included environmental hazards and residential characteristics. So they encompass a number of things. And the methods. So as I said before, we undertook a systematic review. And I'll just go through the search process briefly. So we looked at various different databases, Medline, Embase, PsycInfo and CINAHL. And we used three main blocks of search terms: patient safety, system and contributory factors, and care homes. And we also looked through the grey literature using these search terms in Google Scholar. On our inclusion criteria, so we focused on studies looking at contributory factors to safety incidents for older residents, so those over 65, in care homes, nursing or residential. And we included both quantitative, including randomised controlled trials, cohort studies, cross-sectional and quasi-experimental studies, mixed methods, qualitative assessments and systematic reviews. Okay, so data selection and extraction. So screening was conducted in 2 stages and we managed it through a software package called Covidence. The eligibility of titles and abstracts were examined by independent pairs of 4 reviewers, and the full text screening was completed by 2 reviewers based on criteria used in a previous review. Disagreements were resolved by discussion and the involvement of a 3rd reviewer. And for data extraction, the key information we extracted were study design, settings, participant demographics, and contributory factors to resident safety. And the domains or sort of areas of contributory factors to resident safety were first coded by 2 independent reviewers and then further validated using 10% of the articles by 2 independent reviewers and clinicians who were experienced in the care of elderly. And this was to ensure a consistent approach. Okay, so the results. This is the Prisma flow diagram that shows you how many studies we screened. So we had 2,713 after the duplicates were removed. And that was for the title and abstract screening. And then we ended up with 180 to be for the full text screening stage. And then eventually, once we'd gone through this process, we had 67 studies that we included in our review. Okay, so these are the main sort of safety domains that we identified. There were 18, I think, that we identified through the review. The top 4 were task performance, team factors, training and education, and communication. And there were 2 sort of new ones that came out of the literature that we hadn't identified in previous reviews, and they were leadership and family related factors. So the next slide gives you sort of a definition of some of the main contributory factor domains. So our main one was, the most common one was task performance, and that's the skill and competence of care home staff when carrying out a task. And then obviously communication is self-explanatory. Family related factors are those that refer to features of the family that make caring for their family members more difficult and therefore more prone to error. Training and education that relates to access to correct, timely and appropriate training for staff working in the care home, both task related and organisational related. Obviously these slides will be shared afterwards if you want to look in more detail. And the next slide is the contributory factors framework diagram, which shows you sort of a diagrammatic representation of all those factors. I realise it's probably not completely clear on the screen, but we're going to send these slides afterwards and a full sort of clearer picture of the original if for anybody that would like to see a original copy. Okay, so just now finally a few points for discussion. So the synthesis of the contributory factors into 18 safety domains demonstrates the multifactorial nature of resident safety, ranging from national policy to individual resident and staff factors. The 5 most common safety domains were task performance, team factors, staff training and education, communication, and organisation and care planning. So the framework can be used in real life practice to allow care home staff to examine and improve the safety of their home and promote effective organisational safety learning. It could be utilised as the backbone of a tool for residents and informal carers to rate their safety in their care home. It could be used to inform the development of an intervention strategies to improve safety by targeting the most important contributory factors to patient safety incidents, and also guide the measurement tools used to evaluate policy and service level interventions. And Natasha and Claire are both going to tell you a little bit more about how we're using the framework for the development of a resident measure of safety, and also looking at the analysis of some qualitative interviews that we've done around residents' interventions for improving safety in care homes around transitions. And I'm going to finish then and pass over to Natasha. So I will stop sharing my screen. And thank you. I'll pass to Natasha.
I'm just going to share my screen. Okay, I think that should be working now. I'm just going to apologise now, I'm not feeling very well, so if anybody can't hear me, then put it in the chat and I'll try and speak up a bit louder. So I'm going to present the study that followed on from Sally's study, and it's using consensus methods to develop a resident/relative measure of safety, which we've called the RMOS in care homes. So why is it important? I think Sally's already covered this, but older people in care homes are particularly vulnerable to experiencing patient safety incidents. And most information recorded about safety is in the form of incident reporting or from the perspective of professionals. But most residents and their key informal carers are able to provide feedback on patient safety and can play a vital role in the success and longevity of patient safety improvements. So patient, or in this case resident, reported safety. So our team's previous work has successfully developed patient reported measures of safety in primary care and hospitals using questionnaires. And this is an example of of Sally's previous work, which is the primary care measure of safety. So just to give you an idea of the sort of thing that we're trying to develop. So it'd be a questionnaire that looks like this, with a Likert scale ranging from strongly disagree to strongly agree. And then a number of items that the people who'd be completing it would complete. So I was able to access out of hours services when needed. I had enough time during the consultation with a healthcare professional. They're just a few examples to let you know what sort of thing we're trying to develop. So the aims and the focus of this study were to develop a patient measure of safety, as in a questionnaire for care homes. Obviously we've called it a resident measure of safety, but yeah, there's a bit of a crossover in terms of terminology. And to adapt the PCP-MOS, which is the primary care patient measure of safety, so that it's more relevant to residents of nursing/residential care homes. So the methods, this work was based on the evidence synthesis of the contributory factors to safety. So it was based on the work that Sally's done. And what we did originally was scan the literature and existing questionnaires to look for any potential factors that influence safety in the evidence. Then the second round was to present all them items from the evidence in 2 online Delphi questionnaires to a stakeholder panel, which I'll describe in the next slide. After that, we did a consensus meeting with a smaller panel, just to discuss the outcomes of that and check if there's anything that wasn't necessarily captured online that we needed to discuss face to face. So a few items from that were reintroduced, a few items were removed, and a few were reworded or combined. At the moment, we're just doing a think aloud method. So that's having participants go through the questionnaire in the current stage and think out loud as they're answering it, so we can understand if there's anything that needs changing or how it might look in practice. And then the final stage is to pilot the questionnaire and conduct statistical analysis to look for the items of the best psychometric properties, so that can then form the final version of the questionnaire. So it'd be a much shorter questionnaire than what we're currently piloting. So in terms of the Delphi process, we had 5 stakeholder groups. We had healthcare professionals, then care home professionals, researchers, carers/relatives, so informal carers in this instance, so they might be friends or relatives, but not people who are paid to provide care, and residents themselves. And we'd ask them to rate items in terms of which ones should be included in the questionnaire. So we presented items like the ones on the left. For example, I'm aware of how to report a complaint if I am unhappy with the care I receive. So we had a panel of 28 members in the second round. There was 2 rounds of voting, and items with low levels of consensus were removed in round 1. So I can show you the results. So we began with 73 statements, so 73 potential items to include in the questionnaire, and the panel agreed that 30 of them should be excluded in round 1. So in round 2, we presented them again with 43 items that had higher levels of consensus, and only 8 statements were excluded in round 2. So then we presented 35 statements in the consensus meeting. So that was to the smaller group on Zoom. I think there's about 10 people in that meeting. And there was no change in the item numbers, but some items were combined and removed. So we ended up with 35 statements, which have gone through to the think aloud process. Here's an example of questions that most of the panel agreed were good. So things like, I am given the option to involve my family or loved ones in my care. I was always treated with dignity and respect. I've always felt that staff listened to me about my concerns. These are the items that would be included and have gone through the process now. Some items of examples that might have been excluded would be things like care home staff were unable to get help from other care home staff when they asked for it. I always knew the roles of the care home staff looking after me. I didn't know who to go to if I needed a question. These ones these weren't the lowest ones, but these were ones that were sort of marginal in terms of exclusion. And some preliminary findings from the Think Aloud study, which we're currently in the process of doing. So the main concern as we got to this stage, and it has been throughout, is who will complete the questionnaire. So initially we wanted it to be a really inclusive questionnaire. We still do. And we plan for it to be a resident measure of safety completed by the resident with some help from relatives. But a lot of the stakeholder work and Think Aloud has revealed that residents and their carers sometimes feel that this kind of questionnaire might be too complex or time consuming, and residents might not be motivated to complete it. So we're currently in the process of discussing whether this should be a relative or carer only tool, or whether we should make adaptations to it to make it more resident friendly. And it'd be great to get some feedback on that in the question and answer session after these presentations. So these were some questions that relatives found difficult to answer. So evidence suggests that when people are receiving care, if they have adequate knowledge and information about the care, they feel safer. But relatives struggle to answer questions about the information and knowledge of residents or professionals. So the questions that they struggled with were things like information regarding my relative/friend's last hospital visit, e.g. test results or medication changes were available to care home staff. So a lot of people said it would be quite difficult for them to make a judgment about what information care home staff have. Another example might be my relative/friend has been informed of any outbreaks of infection in their care home and the action plans to control the further spread. So the people that we spoke to currently have obviously got relatives who are in care homes during COVID, and because the contact's been minimal, so say a lot of people have been reporting only 30 minutes a week, it's quite difficult to know what their relative has been informed about just due to that minimal contact. So that's what we're in the middle of discussing in terms of how to include these sort of items or whether they should be removed from the questionnaire. And the future work, as I've presented before, is to do the pilot and statistical analysis, so to find the questions with the most variability, which will be most useful at highlighting the differences between questions. And yeah, I think that's the end of it. So I'll just pass you over to Claire. I'll stop sharing my screen.
Thanks, Natasha. So I'm just going to pull up my slides now and share my screen. Okay, hopefully everyone can see those okay. So for the final part of this webinar, I'm going to be talking about transitional care interventions for older people that are living in long-term care facilities. Okay, so in terms of the background to this, my colleagues have already done a really kind of good given a lot of detail about why this work is important. So just a very quick recap. That long-term care facility residents are frequent users of hospital services, so they are having more transitions than people that are not in long-term care facilities. And transitions are a particularly vulnerable time for people, as we know, in terms of exposure to potential patient safety incidents, but also in terms of the distress that people can experience when they're moving between hospital and a long-term care facility. So we have a really good opportunity to look at ways to try and reduce the number of transitions that people are experiencing, but also improving the quality of transitions when people do have them. And it is a major challenge for healthcare systems, but it's something that's necessary for us to look at. Okay, so in terms of the aims for this work, the first aim was to examine the effectiveness of transitional care interventions for older people living in long-term care facilities and staff. Then to look at the factors that may impact how effective a transitional care intervention is, or how easy or difficult it is to implement a transitional care intervention. And then finally, to try and identify the aspects of the transitional care pathway where safety issues are potentially more acute. Okay, so in terms of methods, there are two aspects to this study, a systematic review and also qualitative research study as well. So I'm going to start by talking about the systematic review, which was looking at transitional care interventions for this population. And this review is different from previous reviews in the sense that previous reviews have tended to focus on that transition from hospital to home, so home in the community rather than a long-term care facility. So this is the first review to look at transitions involving long-term care facilities. So in terms of our approach to finding relevant studies, we did an extensive search of electronic databases, the databases that are listed on the slide there, from the inception of the database up until earlier this year in 2021. We also searched Google Scholar, and we used a cluster methodology, which is a formal process for looking for qualitative studies and process evaluations, the type of studies where you get that richer data around the factors that are likely to affect how an intervention is implemented, for example. In terms of our inclusion criteria, we were focused on controlled intervention designs. So interventions where you are comparing one group that receives a transitional care intervention with a group that doesn't. We were interested in all types of transitional care interventions, so where people were transferring from hospital to long-term care facility, vice versa, or both ways. And our primary outcome of interest was readmissions, but again, we took a broad brush approach to this and were interested in a whole range of different outcomes, included things like length of stay, quality of life, satisfaction. Okay, so in terms of extraction analysis, we had a two-stage screening process and we managed data in confidence. The eligibility of potential studies was assessed by independent pairs. So we had three reviewers in stage 1 and 6 reviewers in stage 2, and any disagreements about whether or not a study should be included were resolved by discussion. In terms of the analysis for this, we did a meta-analysis. So we were pooling the results across all of the studies that were included. And then we also did a subgroup analysis. So we wanted to look at whether or not involving primary care or community practitioners had any impact on the effectiveness of transitional care interventions. And then we also wanted to look at whether or not an intervention that targeted multiple different areas of focus as opposed to one area had any impact on the effectiveness of transitional care interventions. So in terms of the results, so we, in terms of the quantitative studies that we were looking for, we screened over 13,000 reports, and from that we included 15 studies in the review. And in terms of the qualitative studies that we were looking for, we screened over 1,300 reports, and we included 4 studies in the review. So what I've presented on the right-hand side of the slide are some examples, some screen grabs from some of the studies that we included, so you get a sense of the type of interventions that made it into the review. So just in terms of some of the key characteristics, 2/3 of the studies came from Australia. We didn't include any UK-based research in the review. 6 of the studies were RCTs, and in total, so pooling across all of the 15 studies, there were 32,722 participants or participant records that were included. In terms of the type of transitions, the majority were focused on that hospital to long-term care facility pathway. And in terms of the type of intervention, 6 had a combination in terms of their focus, and 5 were focused primarily on systems level, and 3 were focused on residents, and 1 were focused on staff. Okay, so we found that transitional care interventions were associated with a reduction in readmissions to hospitals and reduced length of stay in emergency departments. So older people allocated to transitional care interventions were 1.7 times less likely to be readmitted to hospital or an emergency department compared to those that allocated to a control group. The findings from our subgroup analysis showed that interventions with a primary care element or interventions that had a multiple focus did not influence the effectiveness of transitional care, but we think this is probably due to the small number of studies that were included in those analyses. Okay, so in terms of the qualitative synthesis that we did, where we were looking at the factors that may determine the effectiveness and implementation of transitional care, we have 3 main findings from that, and those are that the quality of communication and role clarity of staff is likely to affect the effectiveness and implementation of transitional care, along with the quality of information flow and referral pathways, and that engaging community and primary care practitioners is also likely to have an impact on the effectiveness of transitional care. So these findings map nicely onto the domains that came up in Sally's work on contributory factors. So in terms of the qualitative research study, we have conducted semi-structured interviews with 25 participants from different stakeholder groups. So we've spoken to 10 care home staff, 7 healthcare staff, 7 carer and family members, and a resident. And these interviews have been carried out on Zoom due to COVID, and we've transcribed them verbatim, and we are conducting, as we speak, a framework analysis on these. So we are using the contributory factors domains that have come from Sally's review as the framework to look at these interviews. But within that, we are sort of taking a more inductive approach in terms of the sub-themes that come up within those domains. So some of the results coming out of the qualitative reviews in terms of the type of interventions that people think will help to improve transitional care. So in terms of information flow, people are talking about having some sort of electronic record, a discharge summary that can be shared across providers, making sure that discharge summaries highlight things like medication changes. And also perhaps having some sort of personal social information sharing card, so an About Me card form. Communication has been a strong theme that's been coming through, so things like having improved communication through a more standardised discharge process. And then there are sort of patient-related factors as well. So, for example, involving carers more meaningfully in the discharge process. So this analysis is still ongoing. So these are just some of the preliminary findings that are coming up from that. And again, they are sort of mapping nicely onto some of the domains that Sally's identified in her work. So in terms of sort of the next steps for this work, we're holding a co-design event at the end of the month where we are going to present. So I've presented the short list of some of the a short list of some of the interventions that people are suggesting, but we'll present a long list to the attendees of that co-design event, and sort of try and get attendees to prioritise an intervention that we can help to develop further and finesse, and then test through research, so to test its effectiveness. So if anyone, if anyone has any ideas about transitional care interventions that you think we should be including in that discussion, we would love to hear your thoughts on that. Okay, so in terms of the final discussion points from this work, older people living in long-term care facilities experience fewer readmissions when they participate in a transitional care intervention compared to usual care. And it looks like the effectiveness of transitional care interventions for older people living in long-term care facilities may be improved by promoting higher quality communication and role clarity among staff members, building the infrastructure for better information flow and referral pathways, and also potentially engaging primary care and community practitioners as well. So in line with the qualitative findings from the review, the stakeholder interviews are also suggesting interventions that primarily target communication and information flow. So this is some acknowledgements of the other people that have been involved in the studies that we've presented today. So our thanks to those. And thank you for listening. So over to questions, and I'll stop sharing my screen.
Well, how should we do? We should do this. Perhaps we start from the very start and reading out the questions and see who should respond them.
Would you like me to read out the questions, Maria, or would you like to go through them?
Whatever, Susan. If you prefer to read them out, it might be more helpful if you read them out.
Yeah, I can read them out. That's fine. So first, Maria, we had in your presentation, just after your presentation, Kate Byrne asked, can she double check what analysis you used?
Oh, we used meta-ethnography, which is a 7-step approach for analyzing the findings. I mean, I can also share the published paper if you're more interested about the methods that we used.
That would be great if we can maybe put that on the event description afterwards. Yeah, and I'll share that on the MICRA website. Fantastic. Okay, we then had one second. We then had Julia Toman, who asked what was the breakdown in the settings, i.e. how many nursing residential specialisms were considered, LD, dementia, or just older people?
Well, that's a bit difficult to say because these were qualitative studies, and some of them they were using mixed samples, so they were using both from residential and nursing care homes. But mostly in the US, they used more. They had mostly participants from nursing homes, I have to say, and we didn't do a huge split between dementia care and non-dementia care, mainly because this is what we had available at the time. And there was another question which I saw in the chat about whether there were any particular themes of dementia. It might be, but I think mostly staff members that responded from their perspectives about IPC practice in care homes, and they had in their mind the full pool of residents rather than a subgroup of people with dementia. But this is definitely worth exploring about whether these findings actually apply to people with dementia, whether we need something different.
Right. We had a question from Crystal Warmouth, who asked, has the safety framework been shared with the CQC?
Not yet, because we just finished it and we're waiting to develop the measure and then disseminate them together. But we're aiming to do within the next a few months. I'm sorry, and I think this was not a question for me. It was mostly for Natasha and Sally. So if you have to add anything.
No, I think you've covered it, Maria. Actually, yeah. We will we'll plan to disseminate it as widely as possible once we've finished the work, as I think it will be quite useful for a number of different people. And I outlined some of the ways it could be used in the presentation. So if anybody wants to look at it, I'm sure we can share it at this point. Can we, Maria? Is that?
Yeah, definitely.
Yeah.
And can I basically respond to a question that I think we missed? Is from Crystal, who says what are the implications of the meta-ethnography? Well, they're a bit generic, but I mean we come back to the same points as each of the studies that we did as part of the presentations have found. It has to do with the quality of the training and the organizational commitment in training of staff members in care homes, and how they are, how well they're trained, and how this is perceived as part of the culture rather than just random training for some members. It has to do with the information flow and how well the clinical guidance is actually communicated to care homes, and how staff from other healthcare settings like hospitals or primary care are actually able to communicate and develop partnerships with care homes. And finally, there is an element about residents whenever they can have input. So it is also about residents and family members in terms of what they expect from infection prevention and control, because there is a sense that care homes, they should almost look like a home environment, but then it's a bit difficult to apply measures around infection prevention and control while someone feels that they're at their home. So there is an element there about trying to kind of co-design and agree about how an IPC practice would look in care homes, which is quite different from a more hospitalized setting.
Thank you, Maria. We have a question from Jana, who asked, do you have any tools available now which can be used for audits around safety and infection control?
I think there are a few, but we haven't used them yet, and we're trying from some future work to see how they actually can be applied in care homes, because I think there are, but are more generic, not specific for care homes.
Thank you. Kate Burns also asked, and this is on the questionnaire, she said if it's a resident questionnaire, you'll need to consider people who may not have capacity or people with learning disabilities who may really struggle to answer the questions.
Yeah, they're the discussions we're sort of in the process of having, and we're just trying to figure out what's going to be the best way to make that questionnaire work.
And one aspect we wanted to consider is actually involving more carers and trying to get their perspectives whenever the residents cannot participate, and this is going to be part of their empowerment, actually, to see how much they know and where intervention should focus on making sure that carers have an active voice in the care that the residents with learning disabilities or dementia have.
We also have Amy Clotworthy asked, are the tools and models that you're developing intended for other contexts, such as other countries that might have different healthcare systems, organisations of care homes, or provision of care? How much do the reviews and the Delphi studies involve international research and perspectives?
Can I say something about that? So the review around the contributory factors domain was very much international review. I think, if I'm just looking at the results here, actually, So we had studies from the US, Australia, UK, and then 1 or 2 from some of the European countries. Our previous work looking at primary care and contributory factors in primary care to patient safety incidents has actually been a collaboration with some colleagues in Australia. So that the primary care patient measure of safety is very much an international tool. I think going forward, we'd have to look at, because obviously care home settings are quite different in different countries, but I would have thought there would be some commonalities and that we could use the tool internationally in the future. I don't know what anyone else has any thoughts on that.
Yeah, I mean, what I wanted to say is that we used, I think we have been quite balanced, that basically the review was based on international perspectives, but then the Delphi was more like national, because our primary aim was to develop a measure which mainly can meet the needs of the UK care homes, first of all, and then if this can be used more, if this can be useful internationally, we will need more research to know, but some of these factors will definitely be relevant, because it's less about the organization, it's more about the perspective of patients and carers, and this tends to be similar across settings.
Yeah, I think that's right, and it seems to have worked well with our primary care version, so there's no reason not to use it in other countries.
We had a question towards the end from Alison. She said it's a question regarding transitions. She works caring for older people in a community hospital, and many patients are continually asking, when am I going home?
Yeah, and I think that's it's a really common issue, and I think what we can do, Alison, is we can add that to the long list of sort of issues and potential target areas for a transitional care intervention that can then be discussed at our co-design event. So that's when we're going to be looking to sort of select an intervention that we help to develop and test in research, so we can add your suggestion to that list. So thank you for that.
And probably finally, because we're going to have to start wrapping up soon, we had a last question from Kate, who asked, well, she said that she thinks it's really important to empower and support the person living in the homes. And a lot of her research has involved people with learning disabilities. Bear with me.
Sorry, do you want me to explain that? Because I've just realised that there's so many spelling mistakes in that message.
If you want to pop on, Kate,
yeah, sorry. Just to highlight that, I completely agree with you, Maria, that it's about empowering not only the person and their carers, but essentially a lot of my experience with research involving people with a learning disability is that it's seen as the easier option to just go at the carers. And I think in this instance, what we need to be doing is really empowering the person to be involved in their care and highlighting, well, from my experience of somebody living in the home, this is what my safety issues are and my concerns are. And I know quite a lot of other people have said about easy reads, which is great for helping people understand, but that also isn't an easy option some of the time. And if you have quite a long list of questions, then an easy read booklet of 20, 30 pages is more problematic potentially. So it's just something to consider, and even whether a questionnaire is the right way to go for certain people. And I've just highlighted in the bottom that from experience, PPI and doing a lot of PPI is probably the better way to do that, to get that real informed nature for the questionnaire that you're planning.
I think this is a very helpful suggestion, because this is exactly what we wanted to achieve, to make sure that this is first of all for residents. But then we received a lot of resistance in terms of funding, for the additional part of work, in terms of feedback. So at the end, we're not entirely sure how to balance the idea that this is something new for residents to ensure that at least they can provide the views and perspectives, but at the same time to be usable. So we're trying, we might end up with 2 different versions actually, with the care version, and then something much more easier to read, as you suggest, for residents, at least have something that they can use either in the form of questionnaire or a few items that are like guidance or a booklet.
Thanks, Marie.
Okay, I think we're probably going to have to wrap this up now, as we're approaching midday. Just to let everybody know that the recording of this session plus these slides will be available probably at the start of next week on the MICRA website. I can send an email to all attendees letting you know when the slides and the recording are available. Any last words from our panel? If not, well, thank you everyone for attending today. Thank you to our speakers. We thought it was a brilliant session. And thanks for the audience for your participation and the question and answers. And we look forward to seeing you all at future MICRA webinars. Thanks everyone.